Dr. Sushil Kumar, he is head of the Department of Pediatrics and Neonatology, Apollo Hospital, Bilaspur. Presently, he is executive body member for Central IAP from the state of Chhattisgarh. Currently, he is advisory board member for Indian Journal of Practical Pediatrics 2022. I think Dr. Sushil, you can start your lecture.
Very good morning, dear all. Coming directly to the topic, the sepsis mimics in neonate. See, all sick neonates are not septic and they don't need just IV antibiotic. Many times situation does occur when we have to think beyond antibiotic. So we will try to explain it in view of some cases. So the case 1. A full-term mother was found to have fetal bradycardia. So the obstetrician took the mother for LSCS. Baby cried after positive pressure ventilation with AMBU. After delivery, baby was lethargic, neonatal reflexes were depressed, chest bilateral entry present, no RD, abdomen soft, no organomegaly, but heart rate was only 40 per minute, no murmur, CRT was prolonged, and no other obvious congenital anomaly. The routine investigations all were normal, including troponin I, which was negative. ECG P wave was normal, QRS was normal, but rate was only 40 per minute. Chest X-ray normal, echo normal. So basically a case with bradycardia and no other obvious risk factors. Because isolated bradycardia in absence of myocarditis, so we sent sample of mother also for ANA, thinking that probably she is a case of SLE, and because of that there is antibody transmission leading to destruction of the conducting system, and it turned out to be positive. Later on, the report of anti-SSA Rho and anti-SSB La also came, that also turned to be positive. So with that, what do you think? What was the child was having? Child was having basically complete heart block. It was not sepsis, and this was proved also by the serology. The most important part, the immediate treatment was given by isoproterenol, but the child was not improving with that, so permanent pacing was done by the cardiothoracic surgeon, and this was done within 24 hours of birth, that too in Bilaspur, and this was a BBC news because it has been done, this external cardiac pacemaker placement, even in USA after 48 hours of birth. Then coming to the case 2, the newborn, day 2 of life, no obstetric risk factor, no consanguinity, cried immediately after birth, but there was petechiae, purpura, mucosal bleed, and he has vomited also blood once. Rest all were normal. Investigations showed low platelet. So apparently normal baby with low platelet count and no other risk factor. Do you think that it is sepsis? No, it is not sepsis because child is otherwise normal, other cell lines are okay, child is feeding well. So we thought that this is because of the immune destruction of the platelet, and could be mother may be having some SLE, so ANA, but we have done it, that was negative. So we sent the mother HPA, that is human platelet yellow antigen, that was negative. Father HPA was positive, and neonatal HPA was positive. So it is just like RH factor, that where mother is negative, father is positive, and because of that, the baby is positive, leading to destruction of platelet. So this baby doesn't need antibiotic. This baby is a case of neonatal alloimmune thrombocytopenia and needs only platelet transfusion, and sometimes IVIG therapy also. The case 3, the male with no obstetric risk factor cried immediately after birth, no consanguinity, day 8 of life, was lethargic, refusing to feed, vitals were mild tachycardia, severe dehydration, rest all were normal, CNS was mildly depressed. So what we are seeing that a child is refusing feed, is having tachycardia, having severe dehydration, although there is no history of diarrhea. To the contrary, mother was telling that the diaper was quite heavy, not because of stool, but because of urine. So any clue at this juncture? Good amount of urine in spite of dehydration. The blood investigation gave some clue that sodium was very high, potassium was low, but kidney function was normal, urea was normal. So again, kidney was not at fault. So a dehydrated baby, good amount of urine, high sodium, low potassium, what is the diagnosis? Yes, it is congenital adrenal hyperplasia. With that intention only we sent 17-hydroxyprogesterone. This came very high, and the case was diagnosed as salt-losing congenital adrenal hyperplasia and was in need of hydrocortisone, fluorocortisone, sodium chloride, and not antibiotic. Case 4. On day 1 of life, with no obstetric risk factor, no consanguinity, cried immediately after birth. There was bluish discoloration of body. Feeding was normal, only SpO2 was low, and child was having severe cyanosis, and that was not improving with 100% oxygen. His blood investigations were normal. And this blue baby, with all the normal reports, what do you think? In fact, I have shown already this slide. It was a detransposition of great arteries. And why I put this slide? Because, see, this child needs to be given prostaglandin infusion to maintain the patency of ductus, so that at least some mixing should be there of the blood, and needs immediate balloon atrial septostomy, and within 2 weeks, arterial switch procedure also to save him. Day 5. Case 5, this child on day 4 with no obstetric complication, cried immediately after birth, no consanguinity, had excessive crying and bilious vomiting, although stool was normal. So bilious vomiting. And child was dull, reflexes were mildly depressed, rest all were normal except even the abdomen was, no distension and bowel sounds were present. So bilious vomiting soon after birth, what do you think? The first thing which comes in the mind, maybe are we dealing with duodenal atresia? But see, baby was already 4 days old. He has already passed few days. Investigations were normal except the X-ray abdomen that showed double bubble sign and minimal distal bowel gas. So this was basically not a case of duodenal atresia. It was volvulus. It was volvulus, mid-gut volvulus, and because of that, upper GI obstruction was there and bilious vomiting was there. These cases needs immediate surgery. A simply bilious vomiting, thinking कि नहीं कुछ NEC हो रहा है, beginning of sepsis, that's why bilious vomiting. You cannot wait, because otherwise there will be gangrene formation and we will lose the child. So coming to the case 6. Day 7 of life, no obstetric risk factor, history of consanguinity, difficulty in feeding, there was respiratory distress, and bilateral entry was present, retraction was there, abdomen distended, hepatomegaly, CVS S1 S2 normal, there was plus minus murmur, lethargic baby, cry activity diminished, neonatal reflexes diminished, and baby was hypotonic. So 3 systems was involved, means child was having difficulty in feeding, the hepatomegaly, plus minus murmur, and hypotonic, a floppy baby. A floppy baby, when we see, we must consider few treatable causes. One is your SMA, a spinal muscular atrophy. For that, there is enzyme replacement. And but in that, there will be no hepatomegaly. There will not be any cardiac issue. But here, these two were also there. So what was that? Routine investigation normal. Because of hepatomegaly, we did SGPT, it was high. And because of hypotonia, we did CPK, that was also high. Any clue? Yes, somebody has uttered. Chest X-ray will give you clue. This is showing cardiomegaly, ECG, high voltage QRS complex edge, and echo showed the thickening of both ventricle and intraventricular septum. Again, any clue? Pompey. So it was, dried blood spot was sent, and that confirmed that acid alpha glucosidase activity is diminished. This was Pompey. Why it is essential to diagnose this? Because enzyme replacement therapy is available for this disease. So one should try to not to miss it. This is the L-glucosidase alpha enzyme for the treatment of Pompey. Day 7, the last case. Day 7, no obstetric risk factor, cried immediately after birth, history of consanguinity, no facial dysmorphism, poor feeding for last 3 days. Means child was normal for the initial 4 days and developed convulsion. Urine was having little abnormal odor, vitals dehydrated, and child was bradypneic. In fact, immediately soon after arrival, he was intubated and put on ventilator. Cry activity, sucking was depressed. Other system were normal except hypertonia. The blood investigations, CBC, etc., were normal, electrolyte, CSF, even blood ammonia was normal, ABG was showing mild acidosis. So, CT scan was done at the referring center itself that was showing cerebral evidence of cerebral edema, there was chinking of the ventricle, etc. So, a child who was normal for the first 4 days becomes drowsy, develops convulsion, bradypneic, all the reports comes normal, including CSF, and is developing cerebral edema. Any clue? And there was abnormal odor in urine also. So, maple syrup urine disease was considered, and that's why we sent TMS, tandem mass spectrometry, and in that you can see the, well, here the leucine, isoleucine was very high. Similarly, valine was very high. So these are the branch chain amino acids. These were found to be very high, suggesting the diagnosis of MSUD. And GCMS was also sent. This was also showing high branch change amino acid and their metabolites. And it was finally confirmed. We sent whole exome sequencing, and in that they showed that the branch chain alpha ketoacid dehydrogenase gene, this is the gene which was abnormal. This is quite recent case, sent in February only, February. So important to diagnose this maple syrup urine disease because there is formula after the initial stabilization by hydration, hemodialysis, cerebral edema, treatment with mannitol, furosemide, hypertonic saline, and thymine as a coenzyme. We have to put the child on long term this formula having less leucine, isoleucine in valine. With that, I conclude. Thank you.
Any questions from the audience? You can have the
Thank you, sir.
mic.
Very nice presentation. Sir, I have a query regarding your case number 3. You said that it was a case of salt-producing type of CAH. But your investigation in the slide showed that it was a hypernatremia with hypokalemia. Along with pH is normal. But that goes in contrast to CAH. I would also like to ask whether the newborn child was a male or female child.
Male child, that's why there was no viralization.
But why there is hypernatremia and hypokalemia if it is CH and blood pH is normal in a salt-wasting type?
See, because of the dehydration, it was like that.
Why not is Bartter syndrome?
Bartter syndrome, I will tell you one thing. Bartter syndrome usually does not present in neonatal period, this is one. Second, Bartter syndrome we have seen. One more thing is there.
It can present if it's a fetal type, like there are three or four types of Bartter syndrome. Is there.
Yes,
it can
yes.
present with that.
Bartter syndrome, sodium is also low.
No, there is a hypernatremia. See, in CAH, there is deficiency of mineralocorticoid. the action of mineralocorticoid is sodium retention and potassium wasting. So if there is deficiency of mineralocorticoid, you should get hyponatremia and hyperkalemia.
True, true. Agreed,
So
agreed.
why there is hypernatremia and is against that
Just
actually.
reverse, maybe because of dehydration it was like that. You are right, absolutely correct. Your observation is absolutely correct.
Okay, sir. Thank you.
Any other question? Thank you, Dr. Sushil, for such an informative talk. I think this will definitely help us in our day-to-day practice while dealing with the neonates. Thank you.